What can you expect from Connect 2025? Connect is an event that redefines what's possible in pharmacy. Join the Red Sail family all in one place. Learn directly from product experts with classes tailored to getting the most out of your Red Sail solution. PioneerRx, BestRx, NRx, Prime Care, DocuTrack, Delivery Track, and Access LTC. Connect with fellow professionals and Red Sail team members during roundtables, collaborative sessions, and customer panels. Want to experience all that Connect 2025 has to offer? Register now at connectpharmacyconference.com.
What does a pharmacist do? Well, most people might answer that a pharmacist dispenses the medications that my doctor prescribes. Now, I work with a ton of great pharmacists, and one thing that I don't generally see is excitement about pills in a vial. And this is probably because pharmacists have been trained to do so much more. So what can you get excited about in your community? To find out, let's go beyond the scripts. Everyone, welcome back to Beyond the Scripts. I'm your host, Will Tuft from PioneerRx. And today, as always, we have a great guest joining us. This time we have Jennifer Adams joining us from Skaggs College of Pharmacy up in Idaho, right?
Yeah, I'm at Idaho State University.
Awesome. Well, thank you so much for joining us. I wanted to kind of start today with a quick quote. For whatever reason, if you can add a quote from somebody years and years ago, it adds a bit more weight to the current conversation. For some reason, that's how quotes work. But I love this quote from Thomas Edison, where he says, if we all did all the things we are capable of, we would literally astound ourselves. And I think that's especially applicable to the pharmacy profession in your state. So tell me a little bit about what sets Idaho apart from other states.
Yeah, I love that quote, and I do think it applies 100% to pharmacy. I've never seen so much imposter syndrome as we have in pharmacy. But it's interesting. So one of the things that sets Idaho apart is our regulatory model that we use to regulate pharmacists and pharmacy technicians. We use a standard of care regulatory model, which is similar to what physicians and nurses across the country use. And that regulatory model has allowed us to advance pharmacist practice into an autonomous or an independent space. There's a lot of states that allow for broad population-based collaborative practice agreements. And so you see pharmacists providing similar advanced practice services as what you might see in Idaho. The difference here, though, is that people are providing those services and they have the authority to provide those services independently.
Yeah. So you said imposter syndrome, and I think that's really interesting because so many pharmacists, I think, feel the need to kind of relabel or step back from labels, especially the term clinical pharmacist, where, you know, if you're a pharmacist, you are a clinical pharmacist. You've been trained in so many different areas. But it's funny, those lines and titles that, you know, many pharmacies or pharmacists are comfortable with.
You know, it's funny that you mentioned that. I, with a group of colleagues, published an article recently that started with words matter, and I feel like by the end of my pharmacy career, I'm going to have a whole series of articles that start out with words matter. But what you're talking about with clinical pharmacists, have you ever heard the term clinical physician? No. It's just not something that happens outside of pharmacy that we tag these labels on things. Another common one is we say that we teach our students advanced assessment when really we're teaching them all of the skills to develop a differential diagnosis or a working diagnosis. But, oh, no, don't say the D word, right? And we don't diagnose, that sort of thing. And so often in pharmacy, we make up words. Ambulatory care for example, is another area in pharmacy that we've made up something to fit a specific space. You're a clinic-based pharmacist practicing either in primary or specialty care. Nobody outside of pharmacy knows what the words ambulatory care mean. And so it's interesting that you mentioned that, because I feel like we do that in our profession because of the imposter syndrome, not wanting to step on toes of other health professionals, not wanting to appear like we're doing something different. At the end of the day, we are the medication expert in all of these areas, but we do have a tendency to try to do things in a workaround sort of way. Even with billing and pharmacy, oh no, I'm not going to, we'll develop a dummy NDC code that will allow us to bill a medical benefit instead of putting something in place where we're actually billing the medical benefit of a health plan the same way that everybody else in healthcare does. I'm a firm believer we need to stop doing things differently in pharmacy than everybody else in healthcare does.
Yeah. When it comes to those different titles and those different kind of genres, do you think that maybe some of that comes from, the term pharmacist or pharmacist technician for that matter is so broad, and depending on, your business structure, where you're at, if you're the owner, if you are, working in a health system, that role can be so varied. Do you think that maybe some of those terms have kind of come into place to separate their role to an outsider? So if they are communicating with someone who's not a pharmacist, they're able to say, oh no, I'm different than what you see at CVS.
I think there's some of that. And I think some of it is based on communicating to patients, to people in our communities, but also other healthcare providers. But I also think that there's potentially a group of folks that it comes from a more of I hate to say it, but I'll just say it, an elitist place. I'm different and I'm better because I'm clinical and you're not. And it's this idea that if you're a community pharmacist that you're not clinical, and any community pharmacist can tell you that that's silly, right? They're still doing the same drug utilization review that's happening anywhere else, determining, is this the right drug for the right patient? They're still providing clinical services in a lot of ways, whether it's through, CLIA-waive tests that determine this person has flu or strep, and then they're writing a prescription pursuant to that. Whether it's somebody that comes in and says, here's the set of symptoms I'm experiencing, can you help me? Right? Whether it's, I can help you with these things that are over the counter, or I'm going to refer you to your primary care physician, or I'm going to send you to urgent care or the ER, right? We're triaging. Those are clinical skills that are being used no matter what setting you're in.
Yeah. So maybe it's a source of pride saying, I'm passionate about this push forward. So maybe it's a good thing.
We'll see.
So, one of the things that we've kind of talked about for, since I've been involved in the pharmacy realm, I've heard discussions about kind of expanding what pharmacists are able to do, and how they're trained to do so much more than dispensing, obviously. And I found a great article from the Journal of American Pharmacists that says that the standards of care, rather than prescriptive rule-based regulation, are designed to kind of harmonize pharmacists' education and training with their legal scope of practice, which is really interesting because, there's so many different individual fights you could have to, move the profession forward. And it seems like the goalpost is just kind of in a different realm when you're looking at that model.
Yeah. It's interesting that in a standard of care model, it's a board of pharmacy has the ability to change a scope of practice in that model in a way that's a little bit easier and requires less what they call regulatory burden, right? So a regulatory burden would be, the legislature passes a statute that says pharmacists can prescribe auto-injectors, for example. And then the Board of Pharmacy has to write some regulations that go along with that. Well, in a standard of care model, the Board of Pharmacy probably wouldn't have to write much as it would relate to the regulations. It would say that a pharmacist who is going to prescribe an auto-injector would do that within their education, training, and experience and to the appropriate standard of care. And so in this model, when something like that comes along, it makes it a little bit easier for a Board of Pharmacy to regulate it in a way that doesn't require them to write pages and pages and pages of regulation. So when you think about, a Board of Pharmacy's job is to keep the public safe. Their job is to protect the public's health and safety. So if I'm protecting the public's health, I'm also thinking about access to care. So pharmacists being able to provide more services, maybe some basic primary care type services on an independent basis or under collaborative practice. Either way, a standard of care regulatory model allows a Board of Pharmacy to say, okay, I'm going to write minimal regulations to go along with this. Otherwise, the board has to regulate to the worst pharmacist they can imagine, right? If I'm going to allow you to do this, I'm going to make sure that I put so many specific details into the regulation so that no pharmacist can harm anyone, right? So the idea that everybody's going to have the exact same clinical ability and and it's all bad, right? It's that worst pharmacist you can imagine. Everybody's got that same clinical ability. And I'm going to make sure that nobody makes a mistake. And I think we see this with, vaccines, when pharmacists can prescribe and administer vaccines, which is, happening in pretty much every state in the U.S. You have to have 12 hours of ACPE accredited training, which is exactly the APHA training program, 12 hours of ACPE accredited. We're going to have this specific emergency kit available on hand within this many feet away from where the vaccination is occurring, right? Like putting so many specific details to try to prevent harm. And there's really not evidence that a Board of Pharmacy doing that keeps people safer.
Sure.
Versus letting the industry guide what are the standards of practice, what's the standard of care that another person with the same education, training, and experience would provide in that type of a setting. I think it's interesting that there are so many boards of pharmacy. I feel like there's a certain level of hubris to think that, like, as a board member, they can write in all the restrictions in a way that will keep everybody safe. Unless you're bringing in experts on absolutely everything to help you write those regulations, it seems a little bit difficult in my mind to think, like, if I was a member of a board, I would think it would be really hard to think of every possible thing that could go wrong to write into the regulations to protect patients.
Yeah, of course. And, and in that model, like you said, you're kind of, playing to the lowest common denominator where, if you think about what does the top of your license look like, I think you had a slide on this that I saw in Oregon. If you're comparing somebody who has graduated 30 years ago and maybe they've been working in a big box with a very, very limited playbook, the top of their license may not be the same as someone who graduated 5 years ago who's extremely proactive and takes a lot of pride in their clinical focus, right? The top of their license may look a lot different, not only in education, but in comfort level, like you said.
Mm-hmm. Yeah, and it's interesting thinking about that, I think in that presentation that you saw, we talked about practitioners with varying levels of clinical ability, and I might have said mine was pretty low. It's been a number of years since I've practiced in a pharmacy, right? So whether it's you've been in a limited scope of practice, area of practice, or whether it's, you haven't practiced in a while, we need to be able to regulate pharmacists in a way that allows people to take advantage of advanced scope activities if their clinical ability meets that, and not prevent them from excelling and doing well and having that higher level of clinical ability, but also protecting that person with less clinical ability is not going to engage in things that they're not educated and trained to engage in. It's really interesting, I think sometimes people conflate scope of practice and standard of care. They make them into the same thing. So back to my mantra of words matter. In standard of care, it's just a way for a board to penalize somebody's license if they provide care that's outside the standard. And that standard is set based on that individual practitioner's clinical ability. So I'm not going to get compared to somebody whose clinical ability is really high, like that person who graduated 5 years ago and has been doing all sorts of really high-level clinical tasks in their role. I'm not going to be compared to that standard, right? If my employer came to me and asked me to provide a service similar to what that person would be capable of providing, I would have a responsibility to say, that's outside my education and training. I either need more training or I need to find a new job because this is not something that fits for me. And it's interesting because I think there are a lot of people that have talked about this idea of, we've got pharmacists, we've got pharmacy technicians. Is there a middle of the road? Is there like a dispensing only pharmacist? Is a term that I've heard thrown out, and I would argue we should have dispensing only technicians versus before we ever say that there should be dispensing only pharmacists, we're training so far beyond that in the way that we're training our graduates. But this idea of having sort of tiered licensure, like this pharmacist is better than this pharmacist. There's, I think, 4 states that have like that tiered licensure model. With standard of care, you don't need tiered licensure because you're allowing everyone to practice only at the level that they are capable of practicing. And if they go outside of that, that's when the board steps in. And so thinking about advanced scope, right? It's not this fear of, I need to write 20 pages of regulation to that worst pharmacist that I can imagine. It's, we're going to allow this. We're going to give this authority to all pharmacists in the state. And I want every pharmacist in the state practicing at the top of their clinical ability, not the top of their license, right? The top of your license, in most cases, I would argue, is less than most pharmacists' clinical ability. So if that's the case, I for sure want to be able to practice above the top of my license. But in the case where you have really broad independent scope, I want everybody practicing at the top of their clinical ability, at the top of their education and training. I don't want them to be either limited by what their license allows or expected to do more than what they're capable of just because their license allows it.
Yeah. So many different pharmacies out there are geared, in such niche ways because of the passion that they have or the needs of their community or, some outside force is pulling them or pushing them into those different areas. And it seems like there's a lot of freedom there to be able to follow whatever's pulling you towards, a higher calling, furthering your education, expanding your services. It seems like there's a lot more freedom to do that.
Yeah. And it's interesting, too, because those market forces that you're referring to also put restrictions. right? So if I own my own pharmacy and I want every pharmacist in my pharmacy to provide a certain service because that's what my community is asking for, and I see that, from an entrepreneurial perspective, that I can make more money in my store, I can, stay in the black instead of in the red, right? If I'm thinking in that way, I also have to protect my own liability, right? I'm going to make sure that every pharmacist working in my pharmacy is trained to do whatever it is that I'm asking them to do. I have to reduce my own, liability for the organization. Every pharmacist should be, thinking about what's my liability in all of this. I'm also a big advocate for liability insurance for pharmacists and technicians. I think everybody has some level of stake in the game when you're providing any type of services, and you need to keep yourself protected just as much as your employer protects themselves. But those market forces related to liability also protect patients. Right? So if I see that there's this huge clamoring in my community for access to flu and strep tests and prescriptions that go along with that, and I have the scope of practice to do it, I'm going to make sure every technician is very well trained before they administer any of the tests. I'm going to make sure that the pharmacists are well trained and that we have an agreed upon protocol that we're going to use, that if the patient meets these criteria, then we write the prescription. Those are the kinds of things that help an organization reduce their liability. I don't know if you've ever had this experience, but I've gone into urgent care. I have asthma, and I've gone into urgent care and I'm like, I just need an albuterol nebulizer. I'll be fine. They're like, you need a chest x-ray. We're sending you to the ER, right? We can't take care of you here because I was outside their protocol, right? Sure. I have asthma. I have this, they're like, oh, she doesn't check the right boxes for us to be able to take care of her. It's that same sort of thing that happens most likely in community pharmacies as these services are offered. It's the patients have to check the right boxes before we say we're going to treat and care for that patient. Somebody that's more complicated, we're referring those patients out because we don't want to take on the liability of that level of care because maybe that's not something that we've trained our staff for.
Yeah. So that was going to be my next question. If you're, looking at examples of this, I think there's some low-hanging fruit. Obviously, a test and treat situation just makes sense. Just makes life easier for all parties involved. My physician doesn't want me in there getting all of his other patients sick. And I don't want to go through as a patient all the steps that ultimately lead to me going to the pharmacy to get the Tamiflu. So, test and treat makes a lot of sense. A more complex scenario like yours, how does that look at the ground level for a pharmacy when you're looking at those opportunities? Is it something that you're working maybe with a physician for initial diagnosis and then passing the ball off to the pharmacy for that continued treatment with maintenance drugs, or what are some examples and how can that look in the pharmacy itself?
Yeah, I think it depends on what you decide you want to do. And when you decide what you want to do and what you want to treat in your pharmacy, you have to look at it from a big picture perspective. What's the prevalence of diabetes and hypertension in my community? Hyperlipidemia, the big three. What's the prevalence of people with asthma, right? Like if you use that as an example, how many people in my community are likely to have asthma? So what's the possibility, how many people could I potentially treat as it relates to that? Now, if I'm going to treat a patient with asthma, I need to have spirometry testing. I need to be able to do albuterol challenges to make that diagnosis. Unless I'm working with an asthma clinic that's making the diagnosis and saying, hey, we're going to work with this pharmacy to treat these patients. And once we've made that diagnosis, we're gonna hand them off. It's hard to see that partnership because that's part of how the asthma clinic makes their money is by those regular follow-up visits. And so looking at that in particular, I don't know that I see that being a big thing for community pharmacies. But in terms of the maintenance, like if I can't get into my asthma doctor because there aren't very many in my community, it'd be really great if my pharmacist felt comfortable saying, you know what, I'm going to continue her medication for another 3 months because she's having a hard time being able to get in. And that's something that's even different. You know, that's prescription adaptation, whether it's continuing refills, you know, those sorts of things. We're going to keep this patient going until we can get more information. But when it comes to, you know, things like diabetes, hypertension, hyperlipidemia, could a pharmacy be treating those? Absolutely, right? Like there's ClioWave tests that you can get somebody's lipids. You could also, if your authority allowed it in your state, be ordering a full lipid panel for a patient, getting that information, adjusting their medication as needed. Looking at somebody with diabetes, could you diagnose somebody with diabetes with the right testing tools, with the right information? Can you look at a patient and say, yes, this person has diabetes based on their hemoglobin A1C? I was talking with an ambulatory care, for better use, a primary care clinic-based pharmacist. And I asked them, I said, you know, are you ever going into the EMR and adding a diagnosis for a patient? And they were like, yeah, all the time. We have an effort in our health system to make sure that we have accurate information on every patient. So I am updating diagnoses. I'm deleting things that are no longer relevant for that particular patient. I'm adding in new diagnoses and putting that all into the electronic medical record. But it's interesting that that same pharmacist also told me that she doesn't diagnose. And I was like, wait a minute, what? So,
yeah,
you know, ultimately you are, right? Because you have the tools available to you. So when we think about a community pharmacy and what they might do, I could see conditions that are minor and self-limiting. I could see them working on, you know, things where a patient's already had an established diagnosis and just needs some intermediate care, or where somebody's had an established diagnosis and they want to be treated for that established diagnosis at the pharmacy. And then looking at, like, what are some things that reasonably are easy for us to get access to information for? And then this is also where, you know, companies come into play, because I don't know how many community pharmacy software systems have really been thinking about, like, okay, we're going to dispense, but we're also going to provide primary care. How do we have a system that documents all of that? Because a community pharmacy that's venturing into this space, they need to be able to document all of that, but they also need to be able to bill a medical benefit for those services. The easiest thing to do is charge cash, and the market generally will show that there are patients that are willing to do that, willing to pay cash for a service. But ultimately, we're going to need to venture into this space of billing the medical benefit for these services that we're providing. And that's a totally different business model, a different way of, you know, it's not instant payment, right?
Yeah, there can definitely be a much different payment model and time expectations in that arena. And I was going to ask what that looks like from a technology standpoint. You know, do you see pharmacies with an EHR in their, you know, in their pharmacy? Are they communicating independently or through some kind of collaborative practice for billing purposes? You know, what do you see that looking like currently? And then, of course, you know, in the future, it would be great to have all of that just housed within your PMS. And we're seeing medical billing, you know, from some of our products, definitely in the early stages still. You know, I feel like the rule books are still kind of being written in a lot of those arenas.
Yeah, for sure. So it's interesting when we look at medical billing, and there are states that compel payment. You know, they have laws on the books that say that pharmacists have to be paid. Washington is an example there. It's a law that says that you can't discriminate based on who provides the service. Everybody should be paid the same. Not all states have that. And then Oregon also compels payment. I feel like in Idaho, we're kind of lucky and we're benefiting from our neighbors to the west in that we don't really have any laws on the books that compel private payers to pay, but they're all paying. They're all working with pharmacies and pharmacists and clinics to set up these services and to pay for the services. Idaho Medicaid, we did have to add pharmacists to the list of non-physician practitioners within Idaho Medicaid, and we have done that, and we now have pharmacists billing successful claims there through both community pharmacies and through clinics. So really the only place that we can't get paid is for Medicare patients, and definitely had that conversation a couple of times that some of the most vulnerable among us are the only ones that can't have their insurance billed for these services. And hopefully that, as that trend continues across the country and more states are either compelling payment or it's just happening or, through Medicaid, maybe we'll hopefully eventually get there with Medicare.
Yeah, for sure. Yeah, it's funny. There's, so many opportunities to offer care and expand care and really, save insurance companies a lot of money by, offering that preventative care. But the mechanism to bill it seems just out of reach and a lot of scenarios.
Yeah, and it's hard because it's a different business model. You're not paid immediately. It's 30, 60, 90 days. You might have to bill a patient later on for a copay. And they don't typically expect that when they leave a pharmacy that they're going to get a bill in the mail for a copay.
Sure.
So that aspect of things, like the logistics of doing that. I do see it, though, as another opportunity for advanced technician roles. Somebody who becomes that, medical billing expert. We've got people managing inventory. We've got people, technicians that are playing all these different roles, accuracy checking. I learned at our Idaho Society for Health System Pharmacy meeting this weekend that we've got pharmacy technicians in the clinic space, that they're the ones that are doing the INR and getting everything ready in the anticoagulation clinic so that when the pharmacist comes in, it's the absolute most efficient use of their time because the technician has prepared everything for the moment that the pharmacist walks in to meet with the patient. And there's a lot of the management of prior authorization and things like that that's happening in a clinic that technicians are playing roles there that I don't know that anyone, I know at least I was like, I don't know that I ever imagined like that this would happen with a pharmacy technician versus like hiring a CNA, right?
Sure.
And so looking at the roles that techs are playing in the whole process, whether it's medication reconciliation in a health system being solely managed by a team of pharmacy technicians, to things that are happening in clinics, to imagine like in a pharmacy, a patient comes in for their flu vaccine and the only time the pharmacist interacts is to provide some patient education after they've determined this is the right vaccine for this patient. The technician does intake, administers the vaccine, does the whole process, and the pharmacist's amount of time that they're spending with that patient is limited to the things that require a pharmacist level of skill.
Yeah, that's pretty cool because, the technician role is already so varied, but to be able to expand, the possibilities for that technician role is really exciting. It's really empowering, I think, for the entire team to be able to, follow that exciting, passionate drive that they have that got them into pharmacy to begin with.
Yeah. Well, and at the end of the day, they want to make a difference, just like we do, right?
Yeah. I mean, I think everyone, even, it's election season, I think even in politics, most people inherently want to do what's going to help the most people they can, despite political lines, which, make things ugly sometimes. But I think that's and maybe I just have rose-colored glasses, but I think that's an inherent truth. If you're passionate, especially about your job, you're always looking for ways to, march forward and offer something new and continue to grow. So it seems like that's really empowering for a pharmacy at across the board, all of the different team members there. How do you communicate what possibilities are available to your team, do you think? So if you're, an independent pharmacy who's still kind of, doing things the same way you were a few years ago, how do you suggest you start to look for ways to expand?
Well, first and foremost, I'm not a lawyer. None of this is legal advice, right?
Good disclaimer.
But I think you have to figure out what's the full extent of your scope of practice in your state. What's your ability to delegate to a pharmacy technician? Are there limitations on that? And what are they? Like, how can you most effectively use your team? So that's question number one, right? Like, figure that piece out. And then I would say engage the people on your team. What services do you feel like, based on your experience interacting with patients, what services do you feel like our community is clamoring for and having a hard time accessing, right? Like, how many primary care physician clinics are there in my community, or are there not in my community? What are the opportunities? What are the options? And then engaging with your team and having the expectation as an independent pharmacy owner that when that pharmacist, you go to them and you say, hey, I'm thinking that we need to begin developing more clinical services. What services do you think would be best? They tell you. And you say, here it is. Let's develop it. Let's work on this. Let's get there. We can do it together, but let's get there. And having the reminder for them when they have imposter syndrome saying, oh, I can't do this, but engaging them. I think one of the things that I noticed at our meeting this last weekend was how much ownership people take when they're given the opportunity to excel. And when they're given the opportunity to really get to the top of their education and training, right? And to be developing those types of services and practicing in that way, they take such ownership and pride over the services that they are developing and providing. And I love seeing that. I loved seeing the confidence that builds in technicians and pharmacists, and the teams. And so, I would say if you're an independent owner and you're not already engaging in this space in some way, who's that go-getter on your team that might be ready to jump in, but who's also that person that you might have to help prop up along the way? Like, get everybody involved so that people feel ownership in some of those services. You'll be much more likely to succeed with those services if you've got buy-in from your team versus you deciding at the level of ownership and saying, this is what we're doing. And then they're pushing back saying, well, when are we going to have time to do that? How are we going to find, we're already worked to death. What's this going to look like? And having them share in that, right? A little bit of transparency. You know what? Hey, if this service reaches this level of revenue, we can hire another technician. If this service reaches this level of revenue, we can hire another pharmacist. What does that look like in terms of managing the workflow of the service in the environment that already exists?
Yeah. And whether or not most people will admit it, I think, autonomy and engagement are far, far more important than, monetary elements of satisfaction. Of course you need to get paid. I get that. But at the end of the day, what's making you smile on the drive home? I think that's really exciting. So when it comes to your patients.
Hang on 1 second. What you just said was key, engagement. What's the antidote for burnout? Engagement. So if you feel like your team is getting burned out, if you feel like there are folks that are like, I don't want to be a pharmacist anymore, right? Like if you're starting to hear some of that from your team, engagement is the cure, right? Valuing the services that they're already providing and then engaging them in the process in a more meaningful way. And you'll start to see people feeling very different about their future.
Yeah, and for whatever reason, burnout has become such a hot topic post COVID. I don't think it's a new topic. I think we just started talking about it. I think that's been around for quite a while.
Yeah, I would agree. Burnout for sure has been around. It's not something new. I think people are more willing to talk about it. I do think that COVID did put added stress on people. And if you were already at a tipping point, that added stress might have been enough. But I do think that I do think there's hope for the future. And when you are able to engage with the team and get them engaged in what you're doing and what you're trying to achieve, that's really the key that helps them to hope for a future that looks different than what it is in this moment when they're feeling burned out.
Yeah, absolutely. So the other side of that, obviously, is your patients. And I'm convinced that nobody is ever disappointed for any reason other than their expectations were not met. If you go to a fast food drive-through one night and you go to a 5-star restaurant the next night, you can be equally satisfied with those because your expectations for each were very different. So as long as you've been able to align your expectations, you're not going to be disappointed, I think. So how do you go about introducing, all of these new, services or just change in general can be difficult to introduce. And then manage expectations with your patient base going through a change.
Yeah, I think first you have to manage the change with your team. And there's, if I can get a little academic, there's a couple of theorists out there. My favorite personally is Cotter and his version on accelerating change. So you've got to work with your team using those steps. He's got an 8-step model for accelerating change. So having your team accepting the change first. But then when you're working with patients, you're also going to need to be thinking about like the changes and how things are different. And my personal experience has been the better I communicate, the better the patient's expectations are managed. I worked in a community pharmacy and I was the only person there. It's a large chain pharmacy and it's one of the smallest stores in that entire chain that I worked in. And so the in window was the out window. It was, so the expectations of this very small pharmacy, for the patients coming in probably were managed based solely on the size of it. But I worked pretty much by myself the entire time. And so the way that I helped to manage patient expectations was to say, you know what? I really want to be able to provide the appropriate amount of care for your prescription. And as you can see, I'm here by myself. And I need to be able to provide care for yours, but I also have to be able to provide care for everybody else. And it would be really great for me if you could come back to pick this up tomorrow. The earliest I can get it for you is in 3 hours, right? Whatever. Something very reasonable and realistic based on the workflow and the amount of work I had in front of me. But I found that when I was working with a patient to say, you know what, I do want to be able to take care of this for you, and I want to be able to administer your vaccine that you're asking for. And so I'm going to need you to come back at this time, and we'll take care of that. And most cases, if it was, hey, I'm asking them to come back in 3 hours, they're like, oh, no worries, I'll come back tomorrow. No problem. It's not a... once you're clear about the expectations and the intention, right? So it's not just giving clear expectations about when this might realistically be ready and available for them as it related to dispensing, but also the intention of, I need to keep you safe in the care that I'm providing, right? It was that part of the conversation. I think when we start looking at offering clinical services, which, it's been a few years, but I wasn't doing a ton of that back then in terms of clinical services. But if you want to add clinical services, you have to manage the expectations on the dispensing side that you're pulling a pharmacist away from. But you also have to manage the expectations about what that looks like for that clinical service. It's not going to be, I'm going to walk in, get my, rapid flu test and be on my way in less than 10 minutes, right? Like, that's not a realistic expectation. Even if you were going to urgent care, that's not a realistic expectation. So having a patient clearly communicated with about how much time it's expected to take, making sure that they're comfortable with that. I think that clear communication is key.
Yeah, and you totally changed the conversation. So if I were that patient, you turned that into an upsell. You took what could be perceived as a negative to tell the patient, "Oh, I don't have time right now. I need you to come back tomorrow." And you really kind of said, "Hey, I care about you so much. I'm giving you this special treatment, and I want to block off a little bit of time just for you." So all of a sudden, the conversation is in a whole different light. I'm getting something special tomorrow. What a great service I'm getting.
Yeah, and it's interesting because I think, so often it's not the pharmacist that's having that conversation with the patient, it's the technician. And so the better we can train the technicians to have those types of conversations and to communicate on behalf of the pharmacist,
Yeah.
Hey, I've got this great pharmacist who's here and they want to be sure that you get the best care. I want to be sure that you get the best care, right? Like, everybody has ownership in that. And having everyone on the same page that this is how we communicate with every patient. This is how we interact every time. And it's not just about customer service. It's about the people in our community and the care that they need. And it feels different, right?
Yeah, and you can imagine a game of telephone where that really caring message from the pharmacist changes when it goes to the technician who delivers it to the point of sale clerk, who's maybe a lot of times kind of left out of that kind of very focused training and intentionality of patient communication. So, by the time it gets to the patient, are you making sure that your team has that compassionate, tailored message?
Yeah. Yeah, you don't want that game of telephone to end up very different than what you started out with.
Yeah, because, if you're not careful, that end conversation could be, "We're too busy. Come back tomorrow, please," which, is the same meaning but much different delivery. So, kind of running low on time here, but let's zoom out a little bit, and I know so many states all have different initiatives that are pushing for, ways to expand not only the financial opportunities, but, just expanding what a pharmacist can do. Can they test and treat? Some states can't have collaborative practice agreements even still, Yeah,
there's
what do you think?
Two left.
Yeah. Yeah.
Delaware and Puerto Rico.
It seems like a no-brainer.
Yeah.
So, how do you think Idaho is setting an example? And Idaho's not the only state, correct? There's a couple.
Yeah. So as it relates to a standard of care regulatory model, Idaho, and then Alaska was next, and then Iowa. And it's out for public comment right now, and hopefully will be approved in New Mexico in the next couple of weeks.
Oh, wow.
Yeah.
Very cool.
Yeah. And all of those 4 states have varying levels of scope of practice in addition to standard of care. But standard of care as the model is the piece that I think every state should be advocating for first. So back to your sort of initial piece of your question. If I was going to advocate to anyone, it would be get this model in place. everybody says, oh, well, the physicians are going to oppose that in my state. And they actually tend to not. In fact, they're like, oh, well, this is how we've been regulated, but why weren't you regulated like this, right? Physicians have been regulated in that way for years. Nurses have been regulated in that way for years. And so the changing in how a pharmacist can be punished by a board, people don't pay attention to, right? Because that's what standard of care does. Then when you have that in place and you want to increase your scope of practice, then you can increase your scope of practice and you take some of the usual arguments off the table. Because the top two arguments are it's not safe and they're not trained. And you're demonstrating that if it's not safe and they're not trained, then the board can penalize that person. And that's really what happened in Idaho is, we put standard of care in place and had some basic independent prescribing of some very specific things when that went into place. Eventually, we were able to remove some of those statutes and regulations that were super specific because of the standard of care piece being in place. Then the independent prescribing moved to 4 categories of prescribing, things that were minor and self-limiting, things that didn't require a new diagnosis, things that a pharmacist could diagnose with a CLIA waive test, or things that a pharmacist just determined were an emergency. If you have a law that passes like that in your state, which has happened in Colorado, it's happened in Montana, there's a version of it in Utah, Alaska. If that happens for that level of independent authority based on those broad categories, and you're a board, you're like, how many pages are we going to have to write for this? Because they're trying to imagine all the things that might fit into those categories and how they're going to restrict it and save everybody from that worst pharmacist they can imagine. Well, and this is actually how Alaska ended up with standard of care. They decided to go the standard of care route so that they didn't have to do that. That left flexibility for services. As you might imagine, Alaska is pretty rural, and the opportunity for those extra services is really helpful. And so putting standard of care in place allowed the board to regulate it in a way that was appropriate, allowing for some guardrails around things, but not restricting what services might be offered across the state. So that would be my suggestion. Step 1, get standard of care in place. Step 2, then go back and look at your scope of practice. So, and I get asked all the time, so I'll just tell you, how do you get standard of care in place? It's kind of a three-step process. Number 1, define it in regulation. And this is all in regulation under the Board of Pharmacy, because every Board of Pharmacy in the United States has the authority to penalize a pharmacist who is licensed under their purview, right? So they already have the authority to do this in regulations at the level of the Board of Pharmacy. So step 1, define it. Step 2, put it in your unprofessional conduct. That's already in your rules. Just add it as another piece there. And then step 3 is what we call the general approach to the practice of pharmacy, which is what every state board of pharmacy has the ability to do is, regulate the practice of pharmacy, is to say that if you're going to delegate anything to somebody under your supervision, you're first going to determine, is it expressly prohibited already somewhere in the law? Is it consistent with their education, training, and experience? And is it consistent with the standard of care? And then that encompasses pharmacists and technicians. So that standard of care piece goes across whether it's a task that's delegated or whether it's a task being performed by a pharmacist. So there's your 3-step process to get standard of care.
Yeah, and then you've got a great groundwork to move forward with phase 2, which would be...
Yeah, so phase 2, there's actually an article in JAFA called How to Implement Standard of Care that I may or may not be an author on. And it's an additional 5 steps of what you would do once you got the model in place.
Great. Maybe you can send me a link to that and we can include that in the show notes.
Yeah, that'd be great. Happy to.
All right. Well, thank you so much for joining us. We're about out of time. I think really exciting stuff up there in Idaho. And, I hope you can definitely help to anybody listening find a little bit of inspiration to kind of look around their community and find new ways to serve.
Yeah, I hope so. I often make people feel a little uncomfortable with some of the things that I say and that I encourage. But I do hope that there are folks listening that have found some inspiration. And I put this out there all the time. I'm happy to be a resource and work with just about any state who wants to advocate for this. So hit me up if you need help advocating for standard of care.
Awesome. We'll make sure you have some contact information in the show notes as well. So thank you so much for joining us. I know you have a busy schedule, and I know you've been traveling and going to different trade shows. So thank you so much for carving out a little bit of extra time for us.
Absolutely. Thanks for having me.
Thank you for listening to this episode of Beyond the Scripts, presented by the Catalyst Pharmacy Podcast. If you enjoyed this episode, please support our channel by liking, subscribing, and clicking the notification bell so that you'll be notified anytime we post new content. To stay up to date with all of the latest independent pharmacy news and content, follow PioneerRx on your preferred social media platform.